my consultants working in the Neuroscience Directorate itself. And we're growing, ever so growing. For those who who don't know what's been happening in the neuroscience unit, or who is not familiar with Mr. Leslie Oliver, he is one of the pioneering neurosurgeons who trained in Guy's St. Thomas's and worked in the military hospitals, and one of the key figures in the British neurosurgery. From then on, he founded this unit, and we've grown to be one of the largest neuroscience units working in the country. And we provide our services not just to this part of London, but also we extend far and beyond the boundaries of London itself. Before I start, let me thank our sponsors, Bristol Myers Squibb and Pfizer and Allegra, who helped host this event. And my special thanks to Iain for initiating this event several years ago. It is particularly special this year because we've got Mrs. Oliver and her daughter Georgina. Welcome you to this event, please. Yes, thank you. Now, it is with special excitement that I'm pleased to welcome Mr. Andole to our annual gathering and he is one of the top UK political commentators, radio presenter and blogger. For those who are not aware of him, he hosts the daily drive time show in LBC 97.3 FM. And in July 2013, he won the Radio Presenter of the Year award. He's also the managing director of Bite Back Publishing, which is Britain's leading political publisher, and was also an author of more than 20 books. These are only a few of his achievements. I can go on and on about what he's done. But, but if you have ever wondered why you can't take your eyes off a public speaker who's a charismatic, and while some of which others can put you to sleep, well, listen to the next half an hour and you know what I'm talking about. He's going to talk to you today about the NHS, the things that need to be said. I know for a fact that I'm convinced with his views on this topic, but I will challenge you to disagree with what he's going to say. Now, without further ado, let me welcome Iain Andole. Thank you so much. Please.
Well, good morning, ladies and gentlemen. Thank you very much for inviting me. I don't think I've ever given an oration before. Looking through your previous list of speakers, I'm afraid what I'm about to say probably bears little relation to what you've heard in previous years, mainly because I know nothing about neurosurgery, and I'm not about to embark on a change in career. Now, agreeing to give a lecture to an eminent group of people who inevitably know far more about the subject than you do is probably not the wisest thing for a political pundit and broadcaster to do. So I'm not going to tell you how to do your job. In fact, when Sri invited me to do this, I was actually typing out an email saying thanks, but no thanks. And then I thought, no, you know, I am going to do this because there are things that I think I want to say, and I hope you will find of interest. What I'm going to do is attempt to identify some of the issues which I think will dominate the health agenda over the next decade. I want to challenge some of the orthodox NHS thinking and say a few things that I think need to be said but don't always form part of the current debate. Now, in many ways, senior health professionals like yourselves and those in government and opposition have much in common, even if that thought might fill you with a degree of horror. You're all trying to wrestle with the demands of an empowered, knowledgeable 21st century consumer base, while you're all operating within a structure which was designed for a mid-20th century command control system of healthcare provision. There's another commonality of interest. You all have a fair idea of what needs to be done, of what you might do if you were the health secretary, but no one in politics seems to be courageous enough to articulate either the problems or the potential solutions. And sadly, I don't really see that changing under this government, or indeed a future one. No one is prepared to think the unthinkable, say the unsayable, much less implement the doable. Politicians treat the NHS as a political football, insisting on initiative after initiative to prove that there really is action this day, and yet they consistently fail to plan for the long term. They seem to think that structural reform and targets will yield results, and sometimes in the short term they do. But who can really say that they can think of a single health secretary who's been able to plan for the long term of either party? During the 13 years of the last Labour government, there were 6 different health secretaries. The Conservatives under Margaret Thatcher and John Major did a little better and managed 7 in 18 years. The coalition government has had 2 health secretaries so far. So a health secretary serves for an average of a little over 2 years. Of the 15 office holders of this post since 1979, very few had any direct experience of health policy before they took the job. So they spent 6 months reading themselves into the job, and the last 6 months trying to save themselves from being sacked from the job. That gives them each just a year to make an impact. Now, a few years ago, the Adam Smith Institute, as the right-of-centre think tank, published a report which opened with these words: Secretaries of State and their junior ministers come and go with sometimes breathtaking frequency, but the one thing they all have in common is the desire to make headline-grabbing changes to advance their careers. As a result, the NHS is besieged by a bewildering array of initiatives from one minister, only for him or her to be replaced by another minister with their own, often conflicting ideas. Politicians tend to think that they can improve the health service by simply giving orders or setting targets or setting off mobile phones. But such measures always have perverse effects, distorting clinical priorities and encouraging creative accounting. NHS policy should be determined by medical priorities and not by political ones. Have we got a crisis or something? Bearing in mind the NHS is one of the world's, this is me now, not the Adam Smith Institute. Bearing in mind the NHS is one of the world's largest organisations, this way of running it is utter madness. If IBM or Glaxo changed their chief executive every 2 years, their share prices would plummet, and within a short time the company would be considered a basket case. But we constantly hear pleas to take the politics out of the NHS. Liam Fox, when he was Shadow Health Secretary for the Conservatives, said it. Various Labour ministers said it. Andrew Lansley said it. Jeremy Hunt seems to believe it. But surely none of them can be so naive. After all, the fact that the health service eats up £115 billion a year, a sixth of public expenditure, means that the way that money is spent has to be accountable, and that has to be through the political system. Now the trouble is that half this sum has, according to the Wanless report, gone on price inflation and extra pay, 25% to consultants and 23% to GPs. But was that the right thing to do? Voters will be judge and jury on that point. But it had to be a political decision, not one made by a faceless independent board. So any politician who calls for politics to be taken out of the NHS is likely to be doing it to get a cheap round of applause on question time and can safely be ignored. It isn't going to happen, and in my view, nor should it. The Adam Smith Institute says, sorry, I've lost a page now. The Adam Smith Institute reckons that the NHS budget should be set by Parliament every 5 years. Their briefing paper documents the bewildering and counterproductive range of political initiatives and interference which it says has wreaked havoc on our nation's health system. The paper's proposal is for a distinguished panel of health professionals to be appointed to run the NHS, to allocate its budget, determine its priorities and operate it according to medical needs rather than political aims. Now, a YouGov poll shows massive popular support for precisely such a proposal, with 69% in favour and only 12% against. Whatever the merits of these proposals, or those of the Conservatives, an independent NHS is certainly not going to happen when we have such consummate political brains in number 10. Think back to the Gordon Brown government. Now, I'm told that the Deep Clean initiative wasn't thought up by the Department of Health. It came directly from the number 10 policy unit, who gave the Department of Health a few hours in which to consider how to make it work. Well, it was duly announced by the Prime Minister, who made it sound as if this would be the only measure needed to eradicate MRSA and C. difficile from our hospitals. Indeed, when I heard it, I thought, well, that sounds like a deeply sensible measure. That is, until I switched on a 5 Live phone-in and heard a succession of health service professionals slam it. Not a single one of them thought it would work. Not a single one of them was taken in by it. So it was at that point that I wondered whether this gargantuan political brain in number 10 was actually as formidable as we'd all been led to believe, and that if his administration wasn't just as driven by spin as the previous one. And just as a transport secretary is judged on whether their tenure of office is free of a major rail crash or transport disaster, a health secretary is now judged on whether they can keep NHS stories off the front pages of the newspapers. That's why Andrew Lansley had to go and was replaced by a politician with a far better bedside manner. So that's my first thing that needs to be said. You can't actually take the politics out of the NHS. In fact, as I shall explain later, I think we ought to be having a big debate about the NHS, but we're being denied that debate because whenever any politician on the right or the left, but mainly the right, has the temerity to criticise the NHS, he or she is jumped on and warned about the consequences of having a go at a beloved institution. Now, if you point out that outcomes in the NHS are in many areas below other comparable nations, you're accused of denigrating people who work so hard in the NHS, or you're accused of advocating full-scale privatisation, even when you're not. Now, if the NHS can't stand up to robust critique, it does say an awful lot about the arguments of some of its very vocal defenders. And nowhere is this more apparent than in the private sector versus public sector debate, which I think has bedeviled health policy for some time in this country. Now, in my view, this is at the very core of the failure of politicians to provide the leadership the NHS needs. The public good, private bad mindset which bedevils politicians on the left is equally matched by the private good, public bad attitudes often prevalent on the right. Only in this country could this happen. Even in these days of supposed consensus, these attitudes still prevail. Do any of these politicians think people care if they're treated privately or in an NHS hospital, if they get the treatment they want, where they want, when they want it? Of course not. Yet people who use Bupa are made to feel as if they're somehow being elitist, rather than being praised for taking responsibility for their own healthcare and not burdening the NHS with their demands. Beveridge and Bevan never meant for the NHS to have to meet every single demand ever made of it. Two systems can work happily together as long as each respects the other. For too long in this country, Labour politicians have seen private medicine as a class enemy, and Tory politicians have viewed the NHS as something for other people to use, not them. Now, David Cameron makes great play out of the fact that he's a regular user of the NHS. He had a disabled son whose fits made regular overnight stays in his local hospital a normal occurrence for him. His view was shaped by experience. He put the NHS at the top of his agenda. He said his 3 priorities could be summed up in 3 letters, NHS. One of his first acts was to abolish the Tory policy of encouraging private sector healthcare. George Osborne said in opposition, we're having no truck with ideas for some alternative funding mechanism like social insurance, nor are we looking to help fund escape routes from public services for the few who can afford it, which is why we've moved away from the idea of a patient's passport. Well, that's all very well, but where are we going to get the capacity from if the private sector is not embraced in a way that it hasn't been before? And let's not pretend that private sector involvement in the provision of healthcare is actually anything new. Most people use private sector dentists. GPs are effectively in the private sector, as are most osteopaths and physiotherapists. But on radio phone-ins like mine, the idea of charging for NHS services is quite popular in some areas. For example, people ask why the taxpayer should pay for the treatment of people who bring their own misfortune on themselves. People who binge drink on a Friday night and end up clogging up A&E departments, why shouldn't they be charged? People who regret getting a tattoo can apparently in some cases have it removed courtesy of the NHS. But where do you draw the line? Do you charge smokers for lung cancer treatment? Do you charge obese people for diabetes drugs? Another one, I suspect, for the politicians' too difficult box. Now, people questioned when they came to power whether the coalition would also embrace the target-driven culture, which, just shows you should check your printer prints out in the right order, doesn't it? People question whether the Conservatives would also embrace the target-driven culture which so obsessed the previous Labour government. It seemed to be the only way to increase throughput, although NHS managers continue to try to convince us that we can do with fewer and fewer beds, and various management consultants still try to hypnotise us into really believing their reports that people prefer to be treated at home no matter what their affliction. The Conservatives profess to want to abolish the new target culture, yet have so far failed to explain how this can improve capacity. Because the truth is that weakening targets has led to capacity issues in many areas of the NHS. This brings me on to structural issues. I was interested to see Chris Huhne say, before the advent of the coalition, rather courageously, I thought, that the NHS needed to be broken up into local units. Quite what he meant by local, he didn't say. But you and I know that turning around the NHS is like turning around an oil tanker. It takes years, sometimes decades, for structural and organisational changes to come into effect. And by the time you've worked out whether they were right in the first place, it's too late, or we have different priorities. So we've had various forms of local accountability over the past 20 years, but none of which have proved satisfactory. In theory, the smaller versions of primary care trusts ought to have provided that, but they were so often saddled with debt that they couldn't respond to local needs. They therefore had to embark on a rationalisation process which local people could just not buy into. They felt they were being hoodwinked, and that elaborate consultation exercises were generally a sham, and the decision had already been made. I saw this at first hand in North Norfolk, where I was a candidate in the 2005 election. People kept being told that everything was being done in their best interests. They didn't believe it. It even got to the point where people were even less likely to believe the words of a PCT official than those of a politician. People just didn't buy the argument that community hospitals had to close, and that the same level of care could be provided in people's homes. They couldn't see why a local Alzheimer's unit had to be shut only 10 years after it had been built specifically for that purpose. Local people weren't convinced, and local politicians weren't convinced either. And even if they had been, could I, as one of them, have actually had the courage to say so? This culminated in the ridiculous spectacle of the chairman of the Labour Party, Hazel Blears, joining a protest in her own constituency against the closure of a maternity unit her own government wanted to shut. Now, what had brought this about? Was it really all about medical advances, meaning that maternity care needed to be concentrated in one place, or that community hospitals were no longer relevant due to the level of care being provided at major hospitals? Or was it a question of funding? And the NHS is being forced to cut its cloth according to its funding. Now, most people suspect that many of the closures are being forced by the latter rather than the former, and this despite health funding having doubled since 1997. People ask, well, where's the money gone? They blame politicians, but they also blame so-called NHS bureaucrats who seem happy to accept the situation where a hospital has more managers than beds, more managers than nurses. They see an organisation which is top-heavy with middle management, and a cadre of politicians who seem powerless or lack the will to do anything about it. And the thing is, in this ever less deferential society, people simply will not sit there and be told that others know what's best for them. On another level, GPs see it every day in their surgeries. Patients engage in self-diagnosis at a level undreamt of. They look at the internet, and they wonder why, if a drug is available in Texas, they can't be prescribed it locally at their surgery. Some patients even turn up with their laptops to explain to their doctor how they arrived at a particular conclusion. Now doctors realise what politicians have had to put up with for decades. Going back to the issue of funding, and I do so because it permeates, I think, virtually all concerns within the NHS. As I said before, a huge amount of money has been channeled into the NHS in recent years. But it's not just politicians who are failing to see an outcome, it's patients. Even though nearly half of it has gone on meeting inflation and pay increases, a doubling of financial input ought to have led to a double-figure rise in productivity. It hasn't. And people want to know why. There will soon be a funding shortfall of £7 to £15 billion a year. How can this be? Is it a problem of acute financial mismanagement? Is health service inflation really so high? Why are efficiency savings so hard to make? Well, the Wallace report highlighted a real fear that if the NHS does not prove it can use money better for taxpayers, they won't be willing to cough up any more. Wallace said such an expensive service could undermine the widespread political support for the NHS and raise questions about its long-term future. This is perhaps unnecessarily apocalyptic, but it is something which politicians would do well to take note of. Now, we're already seeing in the areas of constitutional issues, Europe and the devolution settlement, that if voters think they're being taken for granted, they react accordingly. Now, we all make judgments on the NHS, depending whether we work for it, we're patients ourselves, or we have family or friends who use the NHS. All our judgments are based on our own experience or those of those close to us. Indeed, doctors, surgeons and nurses are not immune to this, with surveys showing that in some hospitals 70% of those that work there wouldn't want their family members to be treated in their own hospitals, a statistic I find quite amazing. Now, in many ways it's all anecdotal evidence, but that's the only evidence that the individual has got. So when learned academic studies are published that are at variance with our own experiences, we tend to speak out. Clearly, people always tend to highlight the negative rather than the positive, which is why whenever I host a phone-in on my radio show about a particular aspect of the NHS, I'm always careful to solicit positive as well as negative callers. Now, Anne Clwyd, the Labour MP, became a bit of a bête noire for some in the medical profession when she told of the terrible care her husband had received courtesy of a hospital in Cardiff, from which he died. She made a tearful speech in the House of Commons telling of their experience and was later asked by David Cameron to head a review looking into complaints against the NHS. Her report made very sad reading for all concerned with the standards of nursing care, about the standards of nursing care in this country. I regret to say that it chimed with me, for my mother went through a terrible experience at Addenbrooke's Hospital, after which she sadly died. It was a horrible experience for her, for my father, for my sisters and for myself. Throughout it all, we felt powerless. It turns out she was put on the Liverpool care pathway. We were never told about it. No one seemed to be able to tell us what was happening to her. She was put on the wrong drugs. She kept telling us, they're trying to kill me. We put it down to the effects of drugs, but in the end, perhaps she was trying to tell us something that we were too deaf to hear. We put our trust in the hospital and they let us down. More importantly, they let her down. The standard of nursing care was lamentable. Different nurses every day. I reckon she had 150 different nurses in the 3 weeks that she was in that ward. Now, I'd love anyone to be able to tell me how there can be any continuity of care in those circumstances. I queried why, whenever I visited, there was never a nurse that I recognised. Oh, it's the 48-hour week that's to blame, one said, and we get put on different wards every day. Half of them seem to be agency nurses, some with a variable grasp of English. Never a good thing when you're dealing with older patients. They kept trying to feed her totally inappropriate food, when a cursory look at her notes would have told them it was wrong. She was left sometimes for hours in soiled sheets. In the end, my two sisters and I operated a shift system because we couldn't let her be alone in one of Britain's top hospitals. We ignored the visiting hours and the nurses allowed us to because it took work away from them. But the thing is, it wasn't really because there weren't enough nurses, there was. When we eventually realised that my mother was going to die, we decided to take her home. The thought of her dying in that place was too awful for us to contemplate. Now, even then, they were so incompetent that I was forced to book a private ambulance to take her home because the NHS ambulance consistently didn't turn up. She spent 2 weeks at home, and it was here that the NHS did come up trumps, with her wonderful GP visiting twice a day and providing just the support that she and we, her carers, needed. And I shall never forget what that wonderful GP did that week. My mother died at home, looking out in the garden she loved, surrounded by her family. Now, I should have made an official complaint. I should have raised Mary Helmer, the hospital bosses, but you know what? I'm ashamed that I didn't. I couldn't bear the thought of reliving it all. I actually feel that I let my mother down, and perhaps more importantly, I let down those who followed her. While she was lying in there, unable to do anything for herself, I kept thinking about other patients who had no family to care for them. We were in a position to do things, but there are many older people whose families can't or won't support them in the way that we could. And it was only when I read about Anne Clewy's experience that I actually did something about it. She had thousands of letters and emails from people who had gone through exactly the same thing as we did. Blame is easy to ascribe, but it's often misplaced. I thought long and hard about how these things are allowed to happen. And in truth, there is no one single person or group of people who are to blame. And let's face it, blame rarely gets us anywhere. But there are clearly questions to be asked about current standards of nursing care in some of our hospitals. So when I heard Jeremy Hunt say, almost on his first day in the job as Health Secretary, that he was concerned about the fact that nursing care was becoming increasingly depersonalised, my ears pricked up. But when he suggested that nurses should do a year's on-the-job training before embarking on degrees, he was met with a hailstorm of abuse from the usual vested interests. A really stupid idea, said the Royal College of Nursing. A truly pathetic response from an organisation which ought to know better. And it's the very same Royal College which failed to spot the problems at the Mid-Staffs Hospital, or if it did, it kept them to itself with the consequences we know only too well. It seems to me that aspects of nursing training are no longer fit for purpose. Just a fortnight ago, Jeremy Hunt said this culture of defensiveness must cease, and doctors and nurses must say sorry when things go wrong in the NHS. Now, administrators blanch at that, saying, well, think of the legal consequences. But surely he's got a point. Of course things will go wrong. In any organisation the size of the NHS, and with the risks involved in most medical procedures, there will always be mistakes, and things will always go wrong on occasion. The challenge for the NHS is to find a way of acknowledging this in a way which doesn't undermine the whole system. I think we also need to look at who we're recruiting into the nursing profession. It seems ridiculous that all nurses are now expected to have degrees or the equivalent. Surely we need a mix of abilities and aptitudes. Where are the good working class girls who used to be the backbone of the nursing profession? They may not have had a GCSE between them, but they knew all about providing fantastic care. They weren't too proud to do the dirtier jobs that some nurses seem to think it isn't their job to do nowadays. I don't know what proportion of nurses in the NHS come from other countries, but how rigorously do we check their backgrounds and qualifications or even linguistic abilities? The NHS would collapse without foreign nurses and doctors, but I've always been slightly queasy about overtly recruiting them from countries which frankly are so poor that the best form of international aid we could offer those countries is not to steal their most capable medical staff. Now, one of the reasons the NHS has required an ever-growing budget is to cope with the challenges of population growth. And over the next couple of decades, the population will grow by 10 million, in large part due to immigration, but also due to a higher birth rate among many immigrant communities. The planning for that should already be underway, but I wonder if it is. Coupled with the added burden of an ever-growing older population, it's no wonder the NHS is already creaking at the seams. But how far can the taxpayers' patience be stretched? As I said at the beginning, we already spend 1/6 of our public expenditure on the NHS. If that proportion is to increase beyond 1/6, some incredibly difficult decisions will have to be taken elsewhere. But what should it rise to? I mean, that's a question that even the new NHS Action Party can't or won't answer. Well, why won't they answer it? A fifth? A quarter? At some point, decisions are going to have to be made about the scope of treatments, restricting the scope of NHS functions, and cutting ever-burgeoning costs. And it's here that I wonder whether the NHS can continue as a truly national